the participant will come in, or do we have to move to a different chat when
No, we stay
stay
here.
here?
I will go live.
Okay, great. Thanks.
Right. We're just letting people in now. Welcome, everyone. We'll just wait a few minutes for everyone to join. I think we can start now. So, welcome. Good afternoon, good morning, good evening to everyone. We welcome you all, particularly those of you who are joining from far away, very late or early in the morning. We really appreciate your interest in EPI-WIN. Thank you for joining this EPI-WIN webinar today. The topic is on Global Public Health Intelligence, WHO operational practices. For those of you who are new to EPI-WIN, this stands for WHO Information Network for Epidemics. It's for science and knowledge translation in health emergencies, and our goal is to translate science to make it accessible, understandable, relevant for evidence-informed actions and decisions in health emergency preparedness and response. And today, we have a great panel. They will share with you the process by which every day WHO systematically detects, verifies, assesses the risk of acute public health threats across the world. This happens every day in the background and helps keep the world safe, so to say. We will have with us Dr. Michelle Yao, who's the Director of Strategic Health Operations here at WHO headquarters, providing the opening remarks. We will then hear from Dr. Esther Hamblion, Unit Head for Public Health Intelligence in WHO, and Dr. Blanche Green-Kremer, who's also from the Public Health Intelligence Unit in WHO. They will talk about WHO's operational public health intelligence processes. Then we learn about of how we work with countries. We have with us Dr. Aura Corpus, who's team lead for public health intelligence in the WHO Eastern Mediterranean region. She will explain to us about working with countries, how WHO EMRO collaborates with the International Health Regulation national focal points on public health intelligence signals. But public health intelligence, the key to it is collaboration with partners. Therefore, we have the privilege of having Mr. Tondri Noe of Public Health Intelligence in UNICEF, and he will explain to us the UNICEF WHO collaboration for working with countries. Before I go on, I'd like to have some housekeeping. As you know, those of you who are regulars here know very well, this webinar is being live streamed on the EPI-WIN YouTube channel. The webinar is being recorded, and afterwards the recording will be available from our website. And I'll share the address with you in the chat shortly. Please bear with us. It may take a few days, but it will be available. We invite you to post your name, location, and organization in the chat box. You're part of the EPI-WIN family. We'd love to know where you're from and what you do. So please do add that to us. And the final housekeeping instructions, so to say, please put your questions in the Q&A. Please don't put it in the chat in case we miss an important question. We'll see it easier if you put it in the Q&A, and it'll be easier for our experts to answer your questions directly. So thank you very much. Before I hand over to our exciting panelists here, we would like to hear from you. It's great that you have so much interest in global public health intelligence, but what do you understand by it? So as usual, slido.com, hashtag 1390223. Please go to slido.com, hashtag 1390223, and answer the question, which is, what do you understand by public health intelligence? Please share your thoughts in 5 words or less. I'm just putting it on the chat here, slido.com. Early warning, AI. Great, we're off to a start. Great. So the biggest ones are community, surveillance, early warning systems, early warning, evolution, a lot on AI, the future, evidence, health policy. Measure nations. Yeah, that's definitely self-care and health. Um, We have some questions also on the Slido in the chat. So it's slido.com. Hashtag 1390223. Great. We have a lot of responses, various different perspectives on public health intelligence. Thank you so much. I will continue to leave the Slido open, but I will stop sharing my my screen here. If you go to slido.com, hashtag 1390223, it's on the chat as well. So please continue to give your responses there. And welcome once again. Unfortunately, Dr. Michelle has been slightly delayed till we join. I would then request Dr. Esther Hamblion to go ahead with the first presentation. She will explain to you WHO operational procedures. Over to you.
Thank you very much, Supriya, and thank you very much to all those who've joined today. I actually really enjoyed that word cloud and seeing everything that was coming out of everything that was coming out there. That'll be useful. So it really is a pleasure to present to you on how WHO undertakes our public health intelligence activities to enhance global health security. Next slide. So we all know that the speed with which health threats are responded to has a significant impact. So in order to respond faster and ultimately save lives, the health threat must be identified quickly. And this is where public health intelligence comes in. So the objective of public health intelligence can be represented as in this graph. We aim to detect events early to enable earlier response, which then prevents additional cases and deaths, thereby flattening the curve, which minimizes the impact at population level on health systems, and as we've seen recently, on economies. Next. Public health events impact individuals and communities on a daily basis in countries across the globe. And as part of ensuring global health security, countries report to WHO events that may constitute a public health emergency of international concern. And last year, there were 365 events that were reported to WHO under the international health regulations from 134 different countries across all regions. And in fact, if we look at this chart on the right-hand side, we can see that nearly 5,000 events have been reported to WHO since 2009 that member states assess as having the potential to have international implications. But then if we look at the chart on the left-hand side, we can see that over the same time period, 8 public health events were actually declared as public health emergencies of international concern. And what this means is this is the highest level WHO gives to show that an event poses a global health threat and requires a coordinated international response. There are currently 2 ongoing public health emergencies of international concern, one being Mpox that was declared in August 2024, and the second being polio that was actually declared back in 2014 and is still ongoing. But this is the aim of our public health intelligence activities. We aim to detect events early to be able to provide any extra support required early to control an event, flatten that curve and reduce their health impacts and prevent them from becoming these public health emergencies of international concern. Next. So the World Health Organization has been undertaking global disease surveillance for many decades. However, it was the 2005 International Health Regulations, which came into force in 2007, that strengthened the global health security. It provides an overarching legal framework that defines countries' rights and obligations in handling public health events and emergencies that have the potential to cross borders. It also established the legal mandate for both the member states of WHO to notify events that may constitute a public health emergency of international concern, but also for WHO to undertake surveillance activities to collect information regarding events and then assess their potential to cause international disease spread and possible interference with international traffic and trade. And it gave us the authority to access and use non-governmental sources of information and to to obtain the verification on these from member states. Next slide. So how do we do this at WHO? Well, it's a mix of both the use of technology, a bit of AI, was mentioned earlier, and essentially personnel. We're a global network of, as well as the 196 states parties to the international health regulations, we have 150 country offices, 6 regional offices, and technical expertise at WHO headquarters. We also have a vast network of partners with specialisms in laboratory or antimicrobial resistance or One Health. And this network of people is really essential for both our intelligence activities and is quite unique to WHO in enabling that support to on-the-ground verification. And we'll hear in a little bit from our colleagues at UNICEF about how we collaborate on sharing some of this information. Next slide. We follow a standardized set of processes at WHO to support the notification and response to public health events, which we've developed over the last few decades. This is actually a cyclical process, and that follows the 5 core steps of detection, verification, risk assessment, reporting or alerting, and then the response. And I'm going to pass over to my colleague, Dr. Green-Karaman, to describe in more detail how we do this on a daily basis, 24/7 here at the World Health Organization.
Thank you, Dr. Hembley. And if we could go to the next slide. So diving a little deeper into our public health intelligence process, you can see on the left side of the slide the flow of information. And this starts with the pieces of information that are gathered through a number of different methods, including non-traditional sources such as media reports, often referred to as event-based surveillance, traditional sources such as routine disease reports, also called indicator-based surveillance, and through the global early warning system for major animal diseases, including zoonosis, more easily referred to as GLUES+, which is a key One Health collaboration between WHO, the Food and Agricultural Organization, and the World Organization for Animal Health. Additionally, as Dr. Hamblian mentioned, we share and receive information with key partners, including UNICEF. The information from these different sources undergoes some preliminary automated filtering and screening, including deduplication and removal of non-relevant information, and this then becomes our pool of raw signals. These raw signals are reviewed by analysts, they're triangulated with other sources of information, and then some are brought forward as potential signals for collaborative assessment at the team level. Signals are then triaged and categorized based on the follow-up action needed, with some of those requiring verification. A subset of verified signals, which we call events, will then undergo a formal rapid risk assessment process that will be discussed a bit later in this presentation. In addition to this flow of information, you'll notice there's a diagram of the international health regulations, consultation, and notification process. And this represents information that is reported to WHO directly by member states, and for us is viewed as already verified and therefore an event. So if we consider what this daily information flow and process generates over the course of the year, we can see that during 2023, around 13 million pieces of information were aggregated from the various sources. Around 1.3 million raw signals were triangulated and assessed by public health intelligence analysts. Around 1,500 signals were then identified, and 40 events underwent the formal WHO rapid risk assessment process. Next slide, please. So what is it that we're actually looking for during this daily process? Broadly speaking, we're looking for any public health concern with the potential to affect human health. And I won't go into all the items that are listed on this slide, but I will highlight a few areas that we focus on, such as when there is a higher than expected mortality or morbidity, particularly when it affects specific populations, such as refugees or healthcare workers, as well as when related to an undiagnosed or unknown illness or death in humans, or unusual death in animals. Additionally, we're interested when there is concern for transmission spread or global impact, such as when there is the potential for a hazard to cause an outbreak with substantial risk of spread. And this can include food safety or security risks, hazards or incidents associated with international trade or mass gathering, or morbidity and mortality from chemical, biological, radionuclear, and environmental hazards. Next slide, please. So what does signal detection, triangulation, and assessment look like more practically speaking? Let's take the recent example of Marburg virus disease in Rwanda. On Friday, the 27th of September, because as we know, these things always happen on Fridays, we simultaneously detected and received information from reliable sources that there were cases of Marburg being reported in Rwanda. Marburg, which is a viral hemorrhagic fever not dissimilar to Ebola, has a high case fatality rate and can spread easily in healthcare settings, meaning it can have a serious public health impact and is something we need to action quickly. In addition to determining the three main epidemiologic parameters of persons affected, place where the event is occurring, and the time frame, one of the first considerations we had was whether or not there had been cases reported in the country before, or if this was in fact the first time the country reported such cases, as this helps us understand the country's capacity for response. We also looked to see where within Rwanda the cases were being reported. Were they near an international border or an urban center with an international airport or port that might increase the risk of spread to other countries? Additionally, we assessed the proximity of these cases to previous outbreaks in neighboring countries. Since we know Marburg is often transmitted to humans from exposure to bats, we looked at whether there were mining communities or recreational cave activities that could have provided initial exposure. And with this initial information gathered by the public health intelligence analyst on duty, this was brought for collaborative assessment, categorization, and then actioning. Next slide, please. So hopefully the example of Marburg gives you a better sense of what we mean with our first step of individual analyst detection, triangulation, and assessment. I'm now going to take a step back and look a bit more broadly about our next step, which is the collaborative assessment. For this assessment, we bring together the multidisciplinary public health intelligence team who cover detecting activities during the entire 24-hour period. This includes individuals with clinical, veterinary, epidemiological, and behavioral backgrounds who have developed expertise in a range of health hazards and geographies to make a final determination on signal categorization and necessary action. The team also reviews signals that have been under active monitoring, new events that have been reported to us by member states, and requests that we've received from other teams across the organization. Outstanding action alerts, alert actions, are reviewed for next steps, and signals are identified for daily reporting and presentation to the WHO Director General and other senior managers for actioning. Next slide, please. So I won't spend too much time discussing signal verification and IHR, as this will be covered in more detail by my colleague, Dr. Corpus, during her presentation later in the session. I will just mention briefly that before response actions are taken, the information related to a signal must be verified, which involves a multi-step process in collaboration with key stakeholders, including the relevant Ministry of Health, WHO offices, technical experts, partners and field teams, and animal health colleagues where appropriate. The purpose of verification is to ascertain enough information to determine appropriate response. Depending on the amount of information that's available to us with the initial signal, verification may include collecting additional information regarding hazard, the location, the people affected, both in terms of the number of people, but also particular population groups, the time frame of the initial onset and spread, laboratory testing that has been done, and case definitions being used. In 2023, 62% of responses to verification requests from WHO to member states were received within 48 hours. Under IHR, states parties have an obligation to notify any potential public health events of international concern within 24 hours. As we've discussed, these potential public health concerns can encompass a wide range of things, but I'll just draw your attention to the right-hand side of the slide where we've noted some of the things that we particularly look for, such as those that are always notifiable, and the 4 questions that we use to determine whether an event is of potential international public health concern. I will leave it there and hand back to Dr. Hamblian to discuss the next steps of our public health intelligence process. Thank you.
Thank you very much. So next slide, please. So once we've verified that an event is happening and has been reported to us through the international health regulations, we then decide to undertake a more detailed risk assessment. And this assesses the risk of an event to adversely impact public health based on the likelihood and severity of the potential consequences. Now, this process uses technical expertise across all levels of the World Health Organization, with consultation of external expertise as necessary. For example, we'll consult with colleagues at the Food and Agricultural Organization or the World Organization for Animal Health on RRAs that may include areas of their expertise. For example, recently on an anthrax outbreak in Zambia or the avian influenza events. But this in-depth assessment on the information available reflects WHO's independent assessment of a country's capacities and vulnerabilities to control that event. Now, one of the key outcomes of the rapid risk assessment process is the decision to activate WHO's emergency response framework and recommends setting up a grading discussion, which enables us to provide more in-depth support to a country for their response. WHO grades an event from 1 to 3, which determines the level of support required. And you can see here on the right-hand side, there are currently over 400 events ongoing globally that have been reported to WHO. And 41 of those are graded. So those are the ones that WHO is providing extra support to a country to respond to. The outputs of the rapid risk assessment also include a recommendation on whether the event should be referred to the International Health Regulations Emergency Committee for consideration as a public health emergency of international concern. The Emergency Committee is a committee of independent experts in the field who provide a recommendation to the Director General of WHO after considering all the evidence as to whether something should be declared a public health emergency of international concern. Next slide, please. And the final key part of our processes is how we alert others to the fact that a public health event is ongoing so that they can enhance their preparedness activities. We regularly share information on confirmed public health events to our member states, and we do this through a dedicated platform called the Event Information Site, which is a secure platform we have with our member states to share information confidentially. This information is compiled by technical experts across the organisation and then is sent to the member state where an event is occurring for their inputs and accuracy check. In 2023, we published around 150 bulletins and announcements about events that were ongoing. Next slide, please. We also share information with the public, both through the Disease Outbreak News, which provides information about outbreaks of international importance, and through situation reports. The Disease Outbreak News were first published in 1996, so more than 25 years ago now, and over the years have become a key WHO communications product. As well as a summary of the known epidemiology, it also provides a summary of the risk assessment that I mentioned earlier, as well as our advice. You can actually subscribe to get DONS by going to the web page that's indicated here and clicking on the subscribe button. As I mentioned, we also utilise other forms of information sharing. For example, at the moment, there is a bi-weekly situation report on the Mpox public health emergency of international concern and a monthly situation report on the global cholera outbreak. We also have emergency dashboards and other event-specific dashboards where you can download data and information. Next slide. So this takes me to the conclusion. I hope we are able to briefly describe, and we haven't got that much time, so sorry, but how our public health intelligence is really fundamental to strengthening the global architecture for health emergency preparedness, response, and resilience. The ability to effectively prevent, prepare for, detect, and respond to health emergencies does depend on the operational readiness and capacities in these 5 interconnected components shown here on the right-hand side. And public health intelligence is essential to these components, particularly as the goal of collaborative surveillance being to enhance public health intelligence, thereby improving the evidence for decision makers to meet the needs of a community. Public health intelligence is also a critical component of emergency coordination and response, and we hope that today we've explained a little bit more about how we operationalise public health intelligence to support this emergency coordination. And if we go to the next slide, if you'd like more information on our processes and outputs or on the type of events that we follow up, please do scan the QR code that's here or copy the link and you can download our most recent annual report. Back to you, Sifria.
Thank you very much, Dr. Esther Hamblion and Dr. Branch Green Kramer, for that overview of how WHO operational processes for public health intelligence works. For those of you who want more information, the links have been put on chat. If you want more questions, you can write to us at EPI-WIN, EPI-WIN at who.int, and we will forward your queries to our experts, to Esther and others. There's a page for disease outbreak news, situation reports, dashboards, and we will share the presentation and the recording with everyone who has registered. It will also be on our webpage. It may take a little bit of time because we have a severe human resource crunch right now, but we will get there for sure. But that you've got the overview. Now we'd like to go to how regions and countries work. How does it work at the country level with WHO? For that, we have Dr. Aura Corpus, who's team lead at the WHO Eastern Mediterranean region. Over to you, Aura.
Thank you, Supriya. Can you share the slides, please? Okay, next slide, please. So this presentation this will be the outline of the presentation. I'll just give an overview of the IHR 2005, the responsible authorities, how we collaborate the PHI signals through verification, some challenging scenarios and how they are addressed, our friendly strategy, a reality check on the challenges of the IHR NFPs, and our way forward. Next slide, please. Next slide, please. So I'll start with the IHR 2005, which is the core or the backbone of the work of the public health intelligence, because its goal is to prevent, control, and respond to the international spread of disease with avoidance of unnecessary interference with international traffic and trade. It has been mentioned already that this is an instrument of international law that is legally binding on 196 countries, and the IHR allows the WHO to take into account information about health events, even from unofficial reports. However, before taking any action, the WHO must request verification from our IHR NFPs. Next slide, please. So let's start with the responsible authorities. How do we operate? How does WHO operate when it comes to verifying the signals that we have identified either through the event-based surveillance, the IBS, or other sources of information? So based on the IHR 2005 Article 4, the WHO is mandated to communicate with the IHR national focal point. It means that there is a unit within the WHO that shall be accessible at all times for the national IHR focal point to communicate. And at the regional office at EMRO, we are accessible 24/7 through the email address that you can see, mroihr@who.int, or our 24/7 mobile phone. This is available to everyone. And also based on the Article 4 of the IHR 2005, there should be a national center at the states parties level designated, which shall be accessible at all times for communications with the WHO IHR contact points under these regulations. And these are particularly on the urgent communication relevant to Article 6 to 12, which you can see. The Article 6 is on notification, Article 9 is on reports, Article 8 is on consultations on some of the events that do not qualify yet to be notified to the WHO, and also some information that are about the other states parties that that may be a threat to that particular states party or some other reports that are available in the country or in the state party. And that is shared with the WHO 24/7. And the WHO also has the responsibility or mandated by the IHR 2005 to verify all this information or signals that we call. Next slide, please. Now, how do we collaborate with the member states on the PHI signals? So through verification, there are reasons, as it has been mentioned already by Dr. Kramer a while ago, there are reasons for the WHO regional IHR contact point to initiate the verification. One is there is a strong indication of international public health implications. And another one is the lack of information or access to additional sources to triangulate the information to assess the public health risk. And at the regional level in EMRO, we have certain criteria that we are looking at in terms of vulnerability and the capacity of the country with regard to a certain signal. Next slide, please. So this is an example of an email that we are sending to our IHR NFPs. So you can see here that we are identifying the source of the information either from the event-based surveillance or, as I've mentioned, either from IBS or indicator-based surveillance or from other informal sources. And then we mention the signal that we want to verify. And of course, we have to identify the link where we have captured this information. And so we also mention in our email if we also have some information from informal sources, and also to facilitate the IHR NFP's information response. We mentioned some of the key questions that we need to identify or they need to respond to. And always we mention that this verification is in accordance with Article 10 of the IHR 2005. Next slide, please. So ideally, these are the responses we are expecting that within 24 hours, there is an initial reply from the IHR NFPs, either acknowledgement of the request from the WHO or within the next 24 hours, available public health information on the status of events requested by the WHO, and information to the WHO in the context of assessment under Article 6, including relevant information. So this is the ideal setting. Next slide, please. However, this is not in reality, this is not the ideal setup. At the regional level, not only in EMRO, but I believe in most of the regions, we are encountering some challenging scenarios. And usually this is a no response after 48 hours or more. So we're expecting at least they acknowledge us, but most of the time there is none. Some vague responses, for example, we are verifying for an unknown disease, and usually they will just respond that some of the differential diagnosis that they are working on, or another vague response is that this is being shared with other departments, or like, for example, a cholera, which is very sensational, or Rift Valley fever, they will just say they don't have cholera in the country, or they don't have RVF in the country. So which is so vague, and we do not know what is actually the response. Are we expecting anything or what? And then another one is the please wait responses, where they say, we acknowledge and please wait. We will get back to you, or please wait, we are verifying it. This has been referred to another department, and it's just a please wait, and we are not receiving anything even after 48 or even 72 hours. So how do we address these things? So first, within the 48 hours, we send another kind reminder or gentle reminder emails, reminding them that based on Article 10, we need to verify this. If there is no response after 24 hours of sending that email, we resort to phone calls. So we have the EIS that has been mentioned by Dr. Dr. Esther, that we have the EIS, the Event Information Site. This is a confidential platform for our IHR NFPs, and all their contact numbers are there. So we contact them by mobile phone, or some through WhatsApp. We take it at the personal level. We send them a WhatsApp message or even call them through the WhatsApp. If this doesn't work, we resort to our country office colleagues. There are some country offices, or most of the country offices also have their IHR focal point. So we go through the country office to mediate for us or to liaise with us to the IHR NFP to follow up our email, our request for verification. And if this is really not working, we now go to our senior management, where usually the regional emergency director getting involved to take part on this verification. Usually he calls the corresponding IHR NFP at the country, usually the WR first, and then we go to the IHR NFP, or even the higher up in the Ministry of Health, especially when it comes to involvement of other countries for a signal that we are verifying. Next slide, please. So usually, as I said, we have also a friendly strategy. They have to feel that we are not just asking information from them. They have to feel that it's a win-win basis, that we are offering something to them, and when they are giving us information. So there is always an offer of support or collaboration when we send that email of request, or even after the response, we offer our support or collaboration. And most of these are on the laboratory, updated WHO guidelines on clinical management, travel advisories, points of entries, an offer of field investigation or a joint mission, a risk assessment, or collaboration with another member states, and any other relevant expertise that we can offer for them to really coordinate with us or collaborate with us in regard to the information that we are asking. And it's not only for information, but for the protection, the global health security. Next slide, please. Just a reality check. There may be challenges from our side, from the WHO side, to get the information, but there are also challenges of the IHR NFPs that we need to understand and we need to operate around. This is the result of our external evaluation conducted for the IHR NFPs in regard to information sharing and notification. So there are actually three main areas of the challenges that the IHR NFPs are encountering. First is in the human resource. At their level, it's not only at the WHO or the UN level that there is a high staff turnover. Also at their level, there is a high staff turnover. That's why there is a limited human resource and competing priorities. And most also, as there are always new people coming in, there are inadequate trainings provided for the IHR NFPs. The second is about the workflow. Usually at the country level, there is an issue between the IHR NFP and the other sectors, as well as between the surveillance and the IHR NFP. The last group is on the legal structure or framework, which is, I believe, the most difficult to handle. There is no legal support, even though we say there is IHR 2005, but inside the country, there is no legal support to facilitate the work of our IHR NFPs, particularly on information sharing and notification. And having said that, there is a multi-channel approval. So our IHR NFPs usually, they have bosses.
Sorry, Aura, if you could start wrapping up a little bit.
Yeah, this is the last. So they need a multi-channel approval, and then inadequate access to the of IHR NFP to decision makers, and the political change or the political situation in the country. Next slide, please. And so with this, our way forward as MRO is to have this high-level advocacy, to push for activities in regard to coordination across the 3 levels within the country and across the sectors, to have communication channel and innovation so that everybody can access any information that they need, trainings, guidelines, and SOPs, and to have motivation for our IHR NFPs. I think that's the last slide. Thank you very much.
Thank you very much, Aura, for explaining in such great depth all the challenges and the way that you work with countries and the challenges in countries as well and how they're overcome. It gives a great overview of how every day the work that all of you do to detect acute public health threats. But now we go over to Tondri Noy from UNICEF to talk about how UNICEF collaborates with WHO. We've heard about how we work with countries, we've heard the global overview, but partners play a critical role. So over to you, Tondri, to let us know about partners.
Yes, thank you very much, Supriya. And first and foremost, I would like to thank the PHI team for this opportunity actually to showcase the strength of our collaboration in early signal detection. And I think above all, how this can support country preparedness and outbreak at country level. So maybe on the next slide, I will start maybe discussing just a little bit how we at UNICEF, what are the sources of the signal that we gather and that we review. So first of all, we do rely on the EIOS, the epidemic intelligence from from open source. We do scan the signals there on a weekly basis. But again, as you know, PHE monitoring is not really the core activity of UNICEF. So we rely a lot on WHO for this. So thank you very much on the PHI team. And then we also get occasionally some signals from other partners as well. Especially from MSF, from CDC, from Africa CDC as well, occasionally. But as you can see here on the picture, the most of our signals are coming actually from WHO PHI team. This is where we get the most of our signals. However, our role is not to duplicate the work of WHO. So when we get all of these signals, we ask ourselves key questions for UNICEF. Are the children, newborn or pregnant women disproportionately affected by these public health events? I think this draws a straight line into the core mandate of UNICEF, which is to protect the rights and well-being of children and pregnant women around the world. Is it a vaccine preventable disease? We do a lot of work in immunization. We have a whole supply division working tirelessly on immunization. So we are really affected by vaccine preventable disease. Is it an unusual event? What I mean by unusual event, I remember a few months ago, we picked up a signal where, school girls were deliberately poisoned while attending school. I think this was very important for UNICEF. It affects children, it affects their education, and it's an unusual event. So we do pick up this type of events. We picked up also the events with high mortality, especially the VHF, Marburg, Ebola. We do also pick up a lot of outbreaks that are currently undiagnosed, because we do follow up all the undiagnosed disease until we know exactly what it is, because it could end up being something that affects children a lot. And also, we do pick up a lot of events that have a wider determinant in terms of health, affecting education, affecting child protection, so all of this. So once we have all of these, signals, and we have filtered actually the signals that are relevant for UNICEF, we do have also signals coming from our regional and country office. This is important because these signals were already assessed at country and regional level. So we gather all of these signals and we move forward. It's also important to understand that, yes, we get a lot of information from the PHI team, but we try also as much as possible to feed back into the PHI, depending on the information that we have. I remember at the beginning of the year, there was an hepatitis E outbreak in South Sudan. Actually, we picked up the information from WHO, but since we have, a big footprint in the community, we were able to get a lot of information, quicker, and we share all of these information with WHO as well. We also have a strong presence in northern Nigeria. We were able to pick up some of the, updates of some of the public health events there. These are things also that we feed back into WHO. So yes, I think the collaboration is quite strong. We do rely a lot on WHO for intelligence gathering, but we do also feedback whenever it's possible. So if we go to the next slide. Yes, so this slide is just to show you a little bit how we process the information within UNICEF. So basically, we have some SOPs in place, but they are based on the 717 targets or framework that is available. 7 days for outbreak detection, 1 day for notification, and then 7 days for to complete the first phase of the response. So basically, in the first 24 hours, we have a signal tracker where we enter all of the signals that we get. We do also, within the 24 hours, we notify our regional offices, our country offices. Within UNICEF, we have several sections. We do pass the information. We do inform also the Emergency Operation Program, EMOPS. And also WHO, depending on where the signals come from. And also within the first 24 hours, we do provide technical guidance, depending on the outbreak, depending on the events. The guidance are made available at regional and country level. Now, within 24 and 48 hours, we do prepare updates, and our associate director for Health Emergency Preparedness and Response will update the Executive Director's Office. And then whenever it's needed, we do propose a 3-level technical call between the health, between the headquarters, between the regional office and the country office, to discuss the way forward together and whether or not this should be moved on a global level. Now, it's important for us to mention here that the way we approach the health, or the way we approach or we assess the signal, will heavily depend on how WHO, or maybe on what grade WHO attributed to that event. I think it was Dr. Esther or Dr. Blanche who recently talked about the grading system. So if WHO grades the event as very important, it is very likely that UNICEF will follow suit and also take this very, very importantly as well. So this is important. So when after the assessment is done internally, if we decide to move forward with the global response, then our associate director of HEPR will identify a coordinator for this event internally within UNICEF at HQ level. We will also start to work on the strategy for search, for the funding, and also to preposition supplies. This is very important. And then, depending on the needs, the associate director will convene internally an advisory group to determine the next level of the response. Next slide, please. So here, I just want to show you a very practical example of how this has worked in the past. So we have many, many examples, but I've just decided to pick one just in the interest of time. On the 24th of October, 2023, we received a signal from WHO, PHI team, about confirmed cases in Mauritania of diphtheria. So the cases were confirmed in the area of Fassala. So Fassala is located southeast of the country of Mauritania, next to the border with Mali. So apparently there were between 8 and 10 confirmed cases of diphtheria in the area. So we received that signal from WHO. We tried to consolidate the data on the 24th, and we communicated actually that information to our regional office in Dakar, Senegal. So they picked up the information on the 25th of October. Actually, they were not aware of the diphtheria situation. So this was, new information for them. So as soon as they picked up the information, they got in touch with the Ministry of Health, from Mauritania. They also got in touch with the WHO office locally to coordinate the response efforts. This was done same day on the 25th of October. And on the 26th of October, so it means 2 days after we received the signals, the response was already ongoing on the field. Actually, UNICEF was, already supporting a network of 383 community relay workers in the community. So on the 26th of October, we activated this network to respond to the outbreak. We activated our RCCE system in place. We were able to get quickly access to funding for vaccination for the 0-dose children. So all of this was done on the 26th of October because we were able to get the information quickly. And then I will go to my last slide.
Okay, I was just going to say, could you
Yes.
please start wrapping up
Okay,
in the
thank you
interest
very
of
much.
time?
So basically, what is the benefits of us working with WHO on early signal detection? First of all, we have access, timely access to signals every day. And of course, here we understand that some of the signals are covered by confidentiality, and we do follow that internally with UNICEF. We do have, this allows us as well to inform our senior management on a very timely manner. But I think the most important thing is that it allows us to react faster and in a timely manner on the field. And I think the Mauritania example underlined this. And then it allows us as well to focus more on our mandates. So UNICEF mandate is not to monitor PHE. This is more WHO. So we do rely a lot of them on WHO. And we focus more on what we do best, WASH activities, RCCE, and, education for children. And maybe I will finish with this one. We are also working with our regional office to better coordinate this signal detection at regional level and also at country level, because we have a very good relationship at HQ level. We also have the same relationship at regional level, but we want to strengthen this relationship so that the response on the field could go faster. So thank you very much, and over to you, Supriya.
very much. We don't have a lot of time left, but we will take maybe one or two questions, and then we're also joined by Dr. Michelle Yao, Director Strategic Health Operations. So I will ask a couple of questions and then invite Dr. Michelle Yao to provide the concluding remarks, if that's okay, in the interest of time. So the first question is to Esther Hamblion. The question is from Pimchanok Ratanapis. I hope I pronounced that correctly. It says, in general, how does WHO verify the news regarding the event, and how long does it take to verify the information? To you, Esther.
Thanks very much, Tim, for that question. Yeah, verification is a really key step of our process, but we work really closely with countries to be able to do that verification. So Dr. Aura explained a little bit about how we do that in terms of linking with what we call the NFP. So that's a particular person who works within the country who can provide that information. Sometimes we hope to get the information quite quickly, which means that we can then inform others about it. So we hope to get the information within 24, 48 hours. But often when an event happens, it could be in a hard to reach place. That does take longer to be able to go and do that investigation. And WHO and other partners are available to support countries in doing that investigation to try and determine the cause of a particular outbreak. Back to you, Supriya. Supriya, you're on mute.
So apologies for that. So I see that. Thank you for your questions. I see most of the questions have been responded to in the Q&A by our experts. So in the interest of time, since we're running a bit late, I would like to request Dr. Michelle Yao to please provide the concluding remarks, so to say. Dr. Michelle Yao also has extensive experience of outbreak response. So over to you.
Thank you very much. Can you hear me?
Yes, we can hear you.
Okay, good. It's just to congratulate the team for the great work done. I think the emergency response cannot be efficient if we don't have an appropriate mechanism or system to detect what event is going on in different countries. And we can see that there is an increasing number of these crises occurring and affecting multi-countries, and it's required also a collaboration. And it was mentioned during the presentation related to IHR. Collaboration is key, is critical. Without that, it's quite difficult for any verification of an ongoing event. And I think the new IHR that has been agreed upon during the last World Health Assembly is trying to strengthen this component, putting in place a robust system that can help countries for a better preparedness, response, and even recovery and resilience, strengthening the different systems. So it's a starting point, but it's a very essential mechanism of having a strong intelligence system to capture quickly. As fast as we can do it, better will be, and efficient, more efficient will be also the response. So very, very, very nice session and highlighting this critical area of work related to response to public health emergencies. Thank you to you all.
Thank you very much, Dr. Michelle Yao. And thanks once again to all our speakers and panelists, to Dr. Esther Hamblion, Dr. Blanche Green-Kremer, Dr. Aura Kobus, who's unfortunately had to rush because she has to go to the airport, and Dr. Tondri Noy. Of course, it was also a great privilege to have Dr. Michelle Yao. But I'd also like to thank everyone who's worked in the background, who's not here today. the Project Echo team, who's organized the run of play, and Noah's here. He's been sharing the slides, doing the background work. My colleagues who are not here today, Sophia Song and Lester Geroy, but who's also helped put this webinar together. And of course, the Public Health Intelligence team as well. But last but not least, to everybody who's participated in this webinar, it's always a pleasure to have you here. With that, thank you. Esther, would you like to say anything?
Thank you to you, Supriya, for giving us the opportunity. I think this topic and this area of conversation, there's clearly a lot of interest from those online. So we look forward to working with some of you in the future. So thank you for the opportunity to have this time.
Thank you. Thank you very much. And if you do have any questions, please write to us as EPI-WIN@who.int, and we will forward your questions to the Public Health Intelligence team or the relevant experts. Please do be in touch. And the next webinar is next Thursday. It's on Africa's RCCE response to Mpox, the country's experience. So look forward to seeing you then. Thank you. Bye.
Thank you very much.
Bye. Thank you.